Great to have you on board, Bill.
Thanks for allowing me back.
Yeah.
Temporary leave of absence.
Yes. In terms of committee members, I would, Bill has rejoined our group and is a fully functioning committee member according to our director, which is wonderful. And other committee members, Robert, are you there?
Yes, I'm here.
Great. And Jeff? Sounds like I didn't see his name yet, so he will probably join us soon. But given that, I think we should go ahead and move forward with today's meeting. So I will call into session the OEBB Strategies on Evidence and Outcomes Work Group for Tuesday, October 5th, 2021. And we see our agenda after approving the synopsis. I've got a phone ringing through. There you are. Hello, Jeff. Okay. Rose, could you go back? I just want to review the agenda. So what you see is after we do the synopsis approval, we then have this is a process that we've been looking at now since the pandemic, and we're trying to get a sense of how things have changed in terms of provision of care. And there's we'll start with medical prevention services and hear from our carriers, then go to telehealth utilization. We'll have a brief break and then go on to dental. So I think it's going to be a full morning. I'm going to be asking questions throughout the meeting and focusing on trying to get as much information as we can on health equity issues as we go through these presentations. It is obviously the focus that OHA has, the state of Oregon has in general, and one that we have been purposed to pay attention to. So, excuse me, my dog just heard the door ring, but we'll go forward. So the first issue is the SEOW September meeting synopsis. Any questions, additions or subtractions or edits? Otherwise, I'll accept the motion to approve.
This is Robert. I will move to approve the minutes as written, or synopsis, sorry.
A second?
I'll second.
Thank you. All in favor?
Aye.
Okay. We have a synopsis approved. Now on to medical prevention services, and looks like we're starting with Kaiser Permanente and Dr. Bachman and Ms. Sturdivant.
Hi, Bill. Welcome back.
Hey, thanks.
Okay, Keith, take it away. You're mute.
Take it away here, and thanks, Tom, and welcome back, Bill, and good to see everybody else. I will just say up front, anyway, we're always happy to talk about preventive services and where we are with HEDIS metrics, and just prevention is key to our philosophy and our model, and it's something that our whole system gets around and feels positively about, and certainly through the periods of the last 18 months where we've not been able to do business as usual and see our patients face-to-face for preventive services, or having to shut down preventive services temporarily, were certainly painful times for us and uncomfortable times. However, when we're putting this together, it was also an opportunity for innovation. As we go through this, we'll be talking about a lot of innovative work that's going on. Some of it hasn't been is in tests of change mode right now. So we're looking at data, trying new things, seeing if they work, and then implementing broader. Certainly, we will also be focusing on health equity, and that's been a key concern of ours for a long time, and even increasing concern over the last couple of years. And how do we provide these services provide all of our services in a way that's accessible for everybody, appropriate for everybody, comfortable, reaching out to people who are more difficult to reach out to, who are for various reasons less likely to obtain these services. When we look at it, we'll show some data at the end, and you can see that in a lot of places the equity story is not what you might think, and communities and race and ethnicity that have been underserved are now no longer underserved in certain places. And that's more complicated because you have to subdivide that by race, ethnicity, language, and location. That said, we'll move on to the next slide and just kind of go through the requested HEDIS metrics. The first one here is child and adolescent well care, and this will be the first time that we present this data. Previously, this was we were looking at a adolescent well care visit, and this is not being separately reported from HEDIS. And you'll see a trend all the way through here. OEB is in orange. Our commercial book of business is in blue, and essentially all of these metrics, things are going to sort of have a similar pattern, with OEB being slightly or significantly above our book of business. And then we just appreciate the high engagement, the health sophistication of our OEB members and their families, and their willingness to take advantage of their Kaiser Permanente health insurance and get great preventive care. The second theme we'll see there through this is just how the numbers have dipped down in late 2020, early 2021, and are all heading back towards normal, but are not quite yet at our peak, the peak levels of care. But anyway, this is a new measure which includes children and adolescents, so well child checks through age 3 to 6, and then again it includes adolescent well care visits, and you can see those numbers coming up over time consistently, with some dips early 2021 related to the, I guess, second or third wave of COVID, and at that point the so anyway, see that there. A lot of the PPE issues that we had in 2020 really aren't an issue now. We still have a certain number of members that don't want to come in to get care and do take advantage of our telehealth services, which we'll also be talking about later today. But things are moving towards normal. You can see the 75th and 90th percentile benchmarks, and we're not quite there yet, but we fully expect to be there, particularly for the OEB population over the next few months.
Hi, Keith. Before you move on to the next slide, is this a cumulative percentage of all child and adolescents, or how am I reading the percentages?
It's percent of children who are in the denominator, which are age 3 to 6, and then again adolescents who have had a yearly documentation of a yearly well child check. So we can say at the current time, as of August 2021, 55% of denominator appropriate OEB children or dependents have been in for a yearly check. These are hard. Not every healthy
great,
kids
thanks.
don't always need it, are busy. High school kids can be really busy. So the number's never, not 100%. So the 90th benchmark is 61.5%. And the 75th percentile benchmark for plans around the country that are HMOs, which are rated a little more stringently than PPOs, is 56.7%. So you'll see the MODO numbers benchmarks being a little bit lower. I don't know if Nathan has anything to add on some of this stuff. Gets pretty detailed and pretty wonky, and Nathan probably knows the details a little bit more than I do on some of the actual specific metrics. So if he wants to bail me out if I'm saying something wrong, please do.
Thanks, Keith. I'll keep an eye on it, but you're doing great so far.
Thanks for the props. Next slide. So these two slides are related to childhood immunization on the left and breast cancer screening on the right. We haven't seen a huge dip. Kids were able to really, through the whole pandemic, come in for their age 2 appropriate vaccinations. Those happen both in well-care visits or in the nurse treatment room as appropriate. What's being followed is combo 2, and you can see again a significant improvement rate of 5% increase rate in OEB kids versus our book of business. And even as we're coming out of this, as of August 2021, the OEB population is now above the 75th percentile, and I assume that'll continue to go up. Breast cancer screening has been more of a challenge. That's been one place where we have seen some reductions over time, particularly for several months where we, last year, where we stopped providing breast cancer screening due to PPE and safety concerns. But those numbers again are coming up with OEB being at 79.7, which even currently is above our 90th percentile. There is an issue with breast cancer screening, and there is some concern it's going to dip down a little bit as we move towards the booster vaccination for many school employees and many of our members, because you don't want to do mammography for 6 weeks after getting a COVID vaccination due to sometimes lymph nodes in the arm that's treated will swell up, which is a mammographic abnormality, which will require additional testing. So we are recommending that women do not get a mammography for 6 weeks after a COVID vaccination. And that's a standard recommendation, but then since there's some uncertainty when people are going to get their COVID vaccination, that can sort of make it, people will less likely to schedule for mammography, want to check the COVID vaccine off the list and then get the mammography screening. We've done something cool digitally, electronically, and I guess you could say how come it took us so long to do this, because in retrospect, it's pretty obvious. So what happens is whenever there's capacity for mammography, whether more sessions have been added or whether some patients have canceled, there electronically sort of a news flash goes out to both schedulers who are scheduling appointments for that day, as well as the teams that says, hey, we have open availability on this day and to get that filled. And so we see that. I mean, we'll just get kind of a news flash on Teams that there's availability. So just as women are being seen in clinic, we can get people, get them scheduled that same day, which is super convenient, and then is better because that increases the throughput and increases capacity, and the machines there would be empty otherwise. So that's one of the things that's going on to improve breast cancer screening. We've also just increased the number of appointments available by making the scheduling, changing the scheduling grid, increasing the hours, and we now have across our region, it's more than 60,000 additional, actually 6,000 additional appointments that we had without changing anything major. So that's what's going on with breast cancer screening. Again, OEB is currently above the 90th percentile as of August 2021, so no concerns about breast cancer screening engagement. Next slide, please. Cervical cancer screening. Now that hasn't dipped as much as some of these other metrics, like colorectal cancer screening on the right, because cervical cancer screening, when everything is going well, is a 5-year look back. A woman comes in and has an HPV test and a simultaneous PAP, cytologic PAP exam. If those are both negative, the next appropriate screening is within 5 years. And so that hasn't dipped as much. And we're, as we move towards more of a regular schedule with 75% of 70 to 75% of visits in the office, there hasn't been a big barrier getting people in for needed PAP examinations on cervical cancer screening. This is one area where Latina women have higher rates of cervical cancer screening than really any of other racial and ethnic groups. So anyway, doing well with that number as well. Again, same trend with OEB doing somewhat better than our book of business. Moving to colorectal cancer screening on the right there, and you can see that pretty massive dip there between January 2020 and August 2020. few things going on there. We actually held off on the outreach because of COVID and concerns of not having capacity in our colonoscopy suites to do colonoscopies as needed. The other reason that dips down very fast in our population is our high use of yearly FIT testing. There is no evidence that colonoscopy, which is kind of the U.S. standard, which is more invasive and more expensive, there's no evidence that that is preferred or better outcomes than a yearly stool tests that looks for hemoglobin in the stool. Using it, FIT stands for fecal immunohistochemical test, and that's what we use. And that's a mail-out test. That's just one stool sample, and we mail that out on a yearly basis. One change and that's only good for 1 year and needs to be repeated every year. If those are positive and there is blood seen, it's not always colon cancer. In fact, it's minority of the time colon cancer. But anybody who has a positive FIT test then needs to have a colonoscopy done. So we ramped that back up, and we are really getting those out there in the community. One test of change that we did with Spanish-speaking individuals, they were sent a FIT kit, obviously with both English and Spanish instructions, and then a bilingual medical assistant called them within 2 weeks, made contact. Often those we found with our Spanish-speaking population that business hours aren't the best, and so we tend to do that kind of outreach on weekends or evenings. The other thing that's going on is the new change in recommendation for colorectal cancer screening in 45 to 50 years old, where colorectal cancer screening in 50 to 75-year-olds is at level A from U.S. Preventative Services Task Force. For 45 to 50-year-olds, it's a level B, which is a less strong recommendation for benefit due to the lower prevalence of colorectal cancer in that population, so that you need to screen a higher number of people to detect one case or prevent one death. So we are making the services available for the 45 to 50-year-old population. We did a big test of change. We actually had 10,000 FIT kits that were about to expire because we had held off on sending some out for a while. And so they did a very controlled test of change, sending them out to 45 to 50-year-olds. They're looking at response rate, who's responding, what language might be best to use, how to reach the 45 to 50-year-old group. So when we do sort of organize outreach to that group, we'll be a little more sophisticated and ahead of the game. And we were able to get the FIT tests back before they expired, which would have been a waste. So again, in OEB, the colorectal cancer screening currently is at 71.4%, which is at the 75th percentile for HEDIS HMO average, and that is going up every month or every quarter, and we anticipate that to become back up to either well above the 75th percentile and likely the 90th percentile within the next several months. Any questions? Moving on to the next slide, and this is not OEB data. This is across our book of business data, which includes Medicaid individual members as well as commercial members. And it's just an example of our health equity work. And we have these as really high priority measures to narrow the gaps that we see here. And so you can see the different race and ethnicities. The blue is everybody. Orange is Black or African American self-identified members. Gray is Asian or Pacific Island members. Yellow, Hispanic or Latinx. Blue is multiracial. That tends to be younger, and so we'll see different engagement in that population. And then green is American Indian or Alaska Native, and then blue is identified as white. Again, we are using the REAL-D questionnaire as an add-on, though we've also had for actually the last 5 to 6 years having people self-identify race as well as preferred language as they check in. So that's 2 sources of data for that. But you can see, so for breast cancer screening, the Hispanic and Latino women have significant see improvements. Are leading for cervical cancer screening as well. Hispanic and Latina are leading, and you can see a relatively lower level among multiracial as well as American Indian, and then colorectal cancer screening. We know Hispanic and Latinx individuals lag a little bit, and that's why we're working on specific outreach to that population. Asian and white in highest screening rates. And then with childhood immunization, you can see how Asian individuals, kids are screened at the highest rate, and Hispanic Latinx, the second highest rate. So it's a complicated picture when we talk about prevention, screening, and the role of race and ethnicity. Geography, there's also variation as well when we look at that. So it's complicated, and we think this work is important and critical, and certainly one of our focuses around throughout our healthcare system in 2021 is really looking at health equity and looking at these important variations, not related to, well, related to chronic condition management services. It was just learned today that we just were able to add a program for automating about 15 different languages onto prescription SIGs. So now the prescriptions, when a member has identified as a specific language, preferred language, all their new prescriptions will be labeled in whatever language of the 15 languages available, which include, non-Latin based languages, can be labeled with those scripts, which leads to better patient safety, medication adherence, and better communication. So, yeah, Tom.
So question, what we have here is race and ethnicity. The other one that you just mentioned in regards to the prescription is primary language, and it'd be fascinating. I don't know if you have the same degree of inclusion in terms of data for language, but it'd be great to see what how this breaks out by primary language.
Yeah, we have that. It's interesting. It depends on in public groups and educators. Language has a very small impact on it, relatively, and then in other groups, and I think is the high level of professionals that are bilingual, they may prefer Spanish, but they don't have the barriers. When you get to groups that have less professionals, where you may have more limited language literacy, you do see very big variation. But we can certainly provide that both across our book of business, commercial book of business, or for OEB specific. We have that broken up as well.
Okay. I will ask the board how they want to proceed with that, but my guess is that I think as a board, we're responsible to look at our population, and if primary language we don't see disparities, that would be great. I mean, obviously, Kaiser Permanente as this regional entity has to pay attention to all the populations that you deal with. So, where you do find it, you have to go after it.
We have it in our standard report, so we'll forward that to you, Tom.
Super. Thank you. That'd be great. Thank you.
Happy to report that back to the board too.
This is Bill. Just confirming, this is OEB data.
This is actually not OEB data. We have.
Oh, okay.
We do have this data.
This is
KP Northwest, which is all lines of business. We do have OEB data for most of this.
And the difficulty, I assume, with trying to get OEB specific data, even with the 30,000 OEB members, it starts. The data can start getting wonky in smaller groups.
For sure. Especially when you have things like child immunization. That is just a few,
Yeah.
a small percent of individuals any given year.
Right. Okay.
As for me, I'm
And
looking
I-
for measures that kind of get us to accelerate people to doing more of the services for OEB, right? I mean, I'd love to discuss the board on how do we increase these numbers for OEB, right? I'm not sure language for OEB members is kind of a key component, maybe male, female, or those things. But the object is to find data that says this is what we need to do to increase the cultural response on preventative and screening measures.
Agreed. So we will look at the OEB specific language information. Okay, thank you, Keith. We still have half an hour, so we're in good shape. Keith, you're going to wrap it up in the next 5 minutes or so?
Yeah. The next two slides are really, I think I've kind of gone through most of what those were when I did just a summary of our strategies and tactics for outreach for the different measures that we talked about today. We can go to the next one. Yeah, I guess for chronic condition management, I mean, that's also, I think may have even bigger racial disparities for, say, diabetes in Latino and Latina members has been a big problem to get that A1C disparity down. A great pilot that's going on in 2 different clinics is a special diabetes service program for Spanish-speaking individuals that is a physician, and these are done in our Salud en Español modules, where everybody from check-in to the medical assistant to nurse to physician to diabetes educators or dietitians are bilingual. And this intervention or this test of change is pretty cool, and just started over the last few months. It involves a physician visit, and then a visit with somebody else in the healthcare staff, which might be a behaviorist, a diabetes educator, or a dietitian who's also Spanish speaking. And then as a gift and as there's a offer of a food box that the clinic staff are putting together, often in conjunction with the local food bank that has fruits and vegetables, other healthy food if the member's interested in that. Just again, food is medicine. We'd rather get our patients to the farmer's market than the pharmacy, right? And so that's something that pilot that we're doing with, and as one of our strategies towards
Where?
improving. That's happening at Sunset Clinic and also in North Lancaster.
Great.
And then one area that's a historical challenge is blood pressure in African American individuals, and that's just, we're really just working through our lists. Some of that's focused in East Portland, some of that's focused at Interstate, and we do find the usual clinical protocol tends to work. It's just a matter of engaging and follow up and making sure that people are offered a wide range of times to make it convenient for them to come in and get checked. We are using more home blood pressure cuff readings when available, but when that's not available, we bring people in the office for blood pressure checks, and then use usually a pharmacy-based protocol, which is really highly effective. That's at bringing down blood pressure in everybody. And then lots of initiatives going on right now with COVID-19, which you can sort of see there. We've doing some door-to-door work with Medical Teams International. We're using some of our predictive analytics, finding people that are both at high risk of getting COVID-19 and haven't yet been vaccinated. We're outreaching to people who we know are immunosuppressed to get them in for their 3rd vaccination. We do have care gaps and outreach for people who are appropriate for a booster vaccination. That's happening there. Using mobile vaccination clinics as a partnership with Medical Teams International. We're working with several other community agencies to get vaccinations in the community. And actually just came out this week was sort of getting clinics motivated to come up with their own innovation projects and offering funding for innovation that involve both kind of clinic and community partnerships. So individual clinics in your own community, how can you innovate to make it fun, get out there and do tests of change, and sort of offering some grants to get medical teams kind of thinking about that, so we can all own the problem and the challenge of under vaccination in underserved and hard to reach populations. With that, we're done. So, Pari, anything to add?
I don't. Thank you so much. That was great.
Any committee members with questions or comments? I'm going to make a comment in that obviously, I think all of you know, I had a 30-year history with Kaiser Permanente, having left in 2013, and I'm really impressed with the changes that have occurred during those last 8 years, and in particular, the focus on being able to look at health disparities and start coming up with ways to address it. So kudos, and just the fact that you have the data allows us to understand what's happening, and then for Keith, you and your health delivery system to be able to address it. We're going to be transitioning now to MODA. Whenever we look at the two different carriers, we get different types of reports, and I think it speaks to the fact that, Keith, what you've just talked about is your health delivery system's response to data that you get in collaboration with the health plan. And when we listen to MODA, what we're hearing is what the health plan can do, and not necessarily what's happening at each of the other delivery systems that MODA uses in its network. So we're going to need to understand that, and then also see how, and I think this will be over time, how MODA is working with its network and health delivery systems to start looking into the issues that we've just talked about. That's my 2 cents. Anybody else want to join in? Otherwise, we'll move on to MODA. Thank you, Keith.
This is Bill.
Thank you, Tom.
Look at this slide.
Yes, Bill.
Oh, I said, looking at the slide, I kind of like a lot of things on this slide, because what we're trying to do is understand our OEB member and their lifestyles and work related issues, and extended lab hours, especially for our teachers and families, is key in getting transportation. Not just the ability to get to the lab to even want to take the test is difficult for the way. So understanding our demographics is good, but understanding how teachers live and how they do family events or family stuff is critical. Doing more tests at home, and the more we can get into modern technology and getting these data from home front without having to travel to a lab is kind of important. So I see that here, and I like it. Including the primary language is important as well.
Great. Okay, on to MODA. Erica? Oh, it's Nathan.
Indeed, yes. Can you guys see me and hear me okay?
I see your name attached to preventive visits. I don't see your face popping up yet, but
I should be displaying my video here. I'm not sure why that's not happening.
I see
okay,
you in
Bill,
your presentation.
I've got old technology, so it's okay.
All right. Great. Thanks, guys. So I'm going to present a bunch of data and then lots of charts and graphs here. So definitely, as we're going through, feel free to chime in with questions. Anything you don't get right away, absolutely just interrupt me, and then we'll get it taken care of as we go through. And if we can go to the next slide. Basically, what this is looking at kind of a refreshed view on some of the preventive services that we've looked at over the last several months, or well, actually over the last couple of years now. We've been presenting this on a month or a quarterly basis. And this is basically, we're looking not at actual HEDIS measures. So we're not doing things like checking continuous enrollment, looking at some of those exclusions. We're really just looking at on a utilization per 1,000 members. And so we try to kind of normalize it a little bit to try to just to give a little bit better picture around how members are actually accessing the services. So it is just a little bit different from some of the HEDIS measures that Dr. Bachman was presenting, but the underlying services are going to be the same. And then we're also looking at the claims between January 1st of 2019 through September 30th of 2021. But we did try to remove those most recent 3 months just because of the claims lag. So we're really trying to look for experience periods through May of 2021. So just a couple of quick kind of things to level set. If we can go to the next slide. This is hopefully a slide that you guys or a graph rather that you guys are pretty familiar with. Which can we go to the next one, please, Rose? There we go. So OHA, I just want to do a quick shout out for them. They've done a tremendous job with their epidemiology data display. And so this one is the epi curve for COVID cases. And so you can see kind of, that pretty low activity through the early part of 2020, but that's really when we had a lot of just unknowns. So just everything was really kind of put on hold. And then we can see kind of, I would say, 3 distinct spikes. So we have one kind of here in that late November, early December time period in 20 to 21. And then we have another one kind of end of April, early May. And then we have this huge one, which we're just starting to come down on that started kind of end of August. So those I think are some things that just key time periods that I want us to kind of keep in mind as we move through some of the different slides. Thinking about the COVID activity is really going to start to have a much bigger impact on how we see some of this utilization change over time. So if we go to the next slide. Here we go. So I've got a kind of a couple series of slides that are pretty similar to this. And the top graph is really just looking at COVID case counts by month. And so this is something that I think is really interesting as we start kind of overlaying COVID activity with their utilization patterns. And so this is for breast cancer screening. This is monthly utilization per 1,000 members. The gray bars on this bottom graph here are 2019. The blue bars are 2020. And then our plum bars here are 2021. And so you can see the kind of 2019 is what we would kind of consider our baseline, kind of a relatively normal year. There are some seasonal fluctuations, so particularly that July and August time period, we see a lot of people getting these services done. This is pretty consistent across the board for most of our preventive services. We really do see a pretty good uptick as we kind of come into that end of summer, kind of start of the school year time period. For looking at the blue bars, we can see kind of some distinct phases. So the early part of the year, we're pretty much on par. This is pre-COVID activity. We're expecting kind of a normal year. And then everything just really shuts down. And we didn't quite get 100% closed services, but we did really limit the number of services that are coming through. MODA stopped messaging members about reminders for care, and it's really around there's just a tremendous amount of uncertainty. A lot of doctors' offices closed for these types of services, as Dr. Bachman was mentioning, and so we started to just really see a slow rebound over the next couple of months, but we didn't quite get all the way to be kind of on par until kind of September and October. But then as we start moving into the end of 2020 and early 2021 year, we start to see some real spikes in our COVID case activity. And about a month after each spike in our COVID cases, we see a decline in our overall utilization for preventive services. So this happens for cervical cancer, it happens for colorectal cancer, it happens for breast cancer screenings. And so as we start moving throughout the year, as we get a spike in COVID, we see a corresponding decline in cases. And so one of the things that we're really watching closely right now is as we're starting to get this claims lag and run out for the end of the summer, how much of this, we get a lot of members screened in this end of summer time period. And so I think we're going to see a little bit more of a depression there as we move throughout that year. So that's definitely something to be aware of as we start looking about nationwide. We know that the benchmarks are down for these measures, but we're just health plans in general and members are really struggling to get access. So this is a really kind of a known gap, but it really ties into COVID engagement. So if we can go to the next slide.
Nathan, this is Tom.
Yeah.
So when do we see MODA's 2020 HEDIS data?
We sent the 2020 HEDIS data to you. I want to say it was end of August. So you should have the 2020 HEDIS report that should have trended 18, 19, and 20 data. But if you didn't get that, I can definitely work there. I can get it over to you later.
It just, I haven't, you know, it's very possible Glenn has it, but we just haven't discussed it. So Glenn, you and I should go over what we have. So go ahead. I'm sorry for interrupting.
Yeah. Oh, no problem. And definitely, okay, no problem. If you want us to come back and present the actual HEDIS data, we can definitely do that too. We just kind of prepared this kind of 3-year overlay on the utilization.
Well, and so. this is what you guys have been presenting on a regular basis. So it's helpful to see the trending. Thank you.
Perfect. So kind of one slight hiccup on this graph. So you can see the June, July, and August data. This is really severely impacted by a claims lag. So I would say just ignore those 3 months. June is getting pretty close to having complete run out at this point, but it's still, I expect this to go up just a little bit more. But similar to the breast cancer screening, we saw just a incredible depression of services as that kind of initial COVID blast hit. But then we start to see a lot more fluctuation based on some of the COVID counts that we see out in the area. And actually, if we can go to the next slide, we're going to a little bit deeper dive on colorectal cancer screening. And I apologize, this one is a bit of an eye test. So I'll kind of walk you through it a little bit. Dr. Bachman mentioned something that I thought was really interesting in his presentation around the bulk of the OEB membership from the Kaiser side is really getting their colorectal cancer screenings done via the FIT test, the FOBT tests. And we don't see that in the MODA population. We see most of the members getting their colonoscopies done as full colonoscopies. And a couple things I wanted to call out was that we are seeing significantly increased utilization. So you can see the gray bar again is 2019. For FIT tests, it's really, really small component. But then for 2020 and then again for 2021, we're seeing increases in those FIT test utilization. So I think that's a great thing. It's shifting kind of towards a less invasive, easier process for members to get get done. Some of those services can actually be done. They can get the kit mailed to their house. They can put a little bit of stool on there and they mail it back. And so the member doesn't even have to interact or interface with anybody to get that accomplished. But we're still not seeing quite as much uptick in the utilization of those as we are seeing kind of the decrease in those colonoscopies. So definitely something to consider and keep an eye on as we move towards closer to the end of the year. Wanting to make sure that maybe if there's some additional incentives, and we are working with our providers pretty closely around giving them as much data as we have around which members are missing some of these services to try to coordinate some of this enhanced care. But I thought that was an interesting difference between kind of what we're seeing on the Kaiser side versus the MODA side.
And this is Tom again for a question. I was actually a little surprised to see the much higher use of the fecal occult test as compared to the FIT test. Has MODA looked at which one is preferable and giving that recommendation to your network, or do you view them as equal?
From the MODA perspective, we really view those as equal. We let the providers kind of dictate and choose, what tests we think are appropriate for them. That's something that each provider makes their own decision based on the clinical evidence. And so as long as members are getting tested by a test that is, clinically appropriate, that's what we really care about.
Okay, thanks.
Yeah. And if we can go on to the next slide, this is just another look at the colorectal cancer screening. So this, I just kind of smoothed out some of those lines a little bit, and just really wanted to highlight a little bit around the distance between the 2019, which is that gray bar, and the blue bar. So that kind of area in between, we would really consider to be kind of where that gap is. So we've got a pretty substantial portion of the population that just didn't get their screenings done in 2020, or I'm sorry, in 2020. And then as we roll into 2021, we can see the plum bar here is still a little bit lower than the gray bar. So we haven't really, for colonoscopies, we haven't really peaked back over and kind of addressed some of this backlog. We did get kind of 2 par for a couple of months, but this is definitely an area where we're still seeing kind of that continued depression of utilization. So definitely something we want to continue to keep an eye on and work on. I think there's a lot changing with colorectal cancer screening, in particular with some of the changing guidance. And so really we're just working with our members and our providers to do a lot of education around, what's changing, what's recommended, how can you get in and get some of these services, or even have these services done in your own house, and avoid having to potentially expose yourself to a place where there might be some COVID activity happening. So we are doing a lot of that education today. But it is something that we rely on the providers to kind of make that choice around what's the appropriate test for their patients. If we can go on to the next slide, please. So this is cervical cancer screening. Again, very similar patterns. One thing that I thought was a little bit encouraging to note for cervical cancer screening was that we do have a number of months here where either the late 2020 or the early 2021 activity is actually higher than the 2019 activity. So this is definitely something that we are seeing pretty close to being on par or even above par as we move through 2021. But based on the spike we saw in COVID cases in April, we did start to see a bit of a decline in those services, April and May. And that's kind of coming right into that high summer seasonality that we expect to see. So again, kind of really keeping a close eye on that data, trying to make sure that we're messaging both the members and the providers as we come into the end of the year to make sure that those do get closed, because we are seeing that this is a little bit of an underperforming measure overall in our HEDIS scores. All right, and if we can go on to the next slide, we are going to shift away from the adult measures. We're going to look at the pediatric measures, and this is something that actually I was really encouraged by. We saw a lot more correlation between the COVID cases and some of those adult preventive services. On the child side, we do see that, so you can see a little bit of that decline in that March, April, May time period on the plum bars there, but it's not nearly as severe as we saw in some of the other cases. And we actually see a quicker recovery in terms of getting back to those services through the end of 2020. And then we stayed pretty much on par with the 2019 to the 2021 utilization. So I think similar to kind of what Dr. Brockman said, we're seeing on the child well-care visits, and this is that newer measure that does go from 3 all the way up to age 21. We are seeing pretty consistent utilization, at least with what we saw in 2019. I think this is definitely still an area where, as Dr. Bachman mentioned, the benchmarks are relatively high nationwide for these. So we definitely do have some room for improvement here. But it's at least that utilization pattern is not nearly as tied to the COVID activity. All right, and if we can go on to the next slide. So this is looking at a couple of different immunizations. So there's a lot of different childhood immunizations. And we did see a little bit of variation in some of the services based on, I think, primarily on when the vaccines were expected to get delivered. So the Varicella is looking at, let me just double check my notes real quick. So it's 2 doses, one in the 12 to 18 months, and then another one in the 4 to 6 years. And we did see a little bit more of a depression there. And I think that's mostly tied to that later dose. Those 4 to 6 year old kids are a little bit healthier. They're not going into the doctor nearly as often for some of those well care checks. And so I think that's really what's tied to that. Whereas the Hep A is focused on those much younger kids. And we saw much less of an impact in that. So I think the younger the children are, the kind of more closely they're adhering to those schedules, and they have just more visits to be able to kind of work with to get things kind of caught back up. All right, and if we can go on to the next slide. I wanted to end on a little bit of a high note. So one thing that I did see was particularly encouraging, and so we have this slide, which is flu vaccines for children 0 to 5. And then the next slide is going to be the same thing, but for adults 18 plus. And the flu activity was quite a bit lower through 2020. But we saw that there was this trend for kids getting their vaccines a little bit earlier. And we saw a very strong vaccine year for flu. So I think there was a lot of concern about kind of that twindemic around COVID and flu kind of correlating together well. And we saw a really strong flu vaccination response. Even though everyone was masking up, schools were closed, there was just a lot going on. I think people were still really concerned about flu and did a great job at getting vaccinated over this last year. We're just getting started in the flu season this year, so we don't really have great data yet around what those vaccination rates look like coming into 2021. But I think this was really encouraging that people were still getting these services throughout kind of the peak of the pandemic. And if we go into the next slide, we can see this similar pattern for the adults, which I think was just again really encouraging and definitely would MODA as an organization, we're working with both our providers and our members as well to really educate and reinforce healthy behaviors like getting your flu shots. So it's definitely something that is kind of top of mind, and this is kind of the season to really get that message out there. All right, and then if we can go to my last slide, just kind of some basic summary. We did see a really significant depression across the board for most of our preventive services, which has mostly recovered, although now we're starting to see a lot more correlation between preventive service utilization and COVID case counts. So as we see COVID cases spike, we see preventive service utilization decline. So I think that's definitely something to consider as we move into this winter period where we're expecting to see another significant spike kind of around that Thanksgiving to Christmas time period. There's a lot of travel. People are just fatigued with some of the COVID prevention processes. And so it's definitely something we really want to keep an eye on and are working as close as we can with both the member and the provider community to really reinforce the need for these preventive services.
Nathan, so my question is, first, thank you for the presentation of the data. It's very helpful. Second, what we saw in our first presentation was stratification by race, ethnicity, and a discussion around language, primary language. Is there, where is MODA at with us being able to look at utilization by those features?
Yeah, that's a great question, and that's definitely something we've done quite a bit of digging into. And I would say, similar to what Dr. Brockman said, it varies a little bit by preventive utilization measure. So things like breast cancer screening, colorectal cancer screening, where we've got large pools of members, we can report some of this data back stratified by race, ethnicity, and language, particularly for some of the childhood immunization measures. The N just gets to be a little bit smaller. And so some of the data just tends to not make as much sense. The other challenge that we have is there's a pretty significant portion of OEBB members in particular that have given us either no response or just left it blank. Or sorry, they were either refused or left it blank for their race and ethnicity, which makes it just really hard to look at differences when we've got, I think it's around 30% of the population has either declined to answer or given us like an other category. So
okay.
That is one of the challenges we're looking at, but we definitely do have some of this data available.
Okay.
Yeah.
So, Eric, if you have something else you want to add?
Yeah, thank you, Nathan. I would just add that, currently we're using race and ethnicity data that comes over from the OEBB file, but we do have our own efforts around finding additional ways to collect more of this data. So you will start to see us starting to incorporate this into our reporting just as we move forward and we're able to get more and more of that data.
Great. Yeah, it just is, it will be in this, you can't start even having the conversation until you have the data. So the the first steps are going to be trying to have that information. The second part would be understanding, having the relationship with your network providers to be understanding what they're doing as entities, and maybe even starting with the top 5 delivery systems that you're working with to understand what their type of outreaches and the like. So we'll talk more about this over time. It's obviously a big issue. We're going to be spending time talking about it this afternoon for the general board meeting, but it will be a constant focus over the next year.
Yes,
Okay.
100% agree.
Yeah. Okay. So any other questions or comments from committee members? Otherwise, we move on to our next discussion, which is the telehealth utilization, and we are exactly on time. So, Dr. Bachman, you're going to start us with this.
Yes, actually, this is Sapari. I'm
Oh,
gonna
hi,
kick us
Sapari.
off. Hi
Okay,
there.
good.
Yeah, I'll kick it off and turn it over to Dr. Bachman. But just a quick intro to this presentation. As we've seen throughout the pandemic, I mean, it has really impacted telehealth utilization. And recently, however, it has definitely evened out. So, you know, we are planning to share that with you today. So next slide, or sorry, Rose, you are already on that slide, sorry. So wanted to just remind everyone how members receive telehealth services through Kaiser Permanente. So, you know, when we think of telehealth, typically it's just the video visits and phone visits, which definitely are the case, and that is what we're reporting on today, in addition to e-visits. And then the piece that, you know, we don't talk about in this presentation is the email component. And just wanted to share a quick statistic with you for OEB specific and how emails really play a factor in telehealth communications for OEB. So for the calendar year 2020, we had over 65,000 or OEB members sent over 65,000 emails to their providers. And that represents about 12,000 unique OEB members actually using the email functionality. And that, as mentioned, you know, the pandemic really has influenced this. And so between 2019 and 2020, we saw a 28% increase in email utilization. Okay, and next slide. And also wanted to remind everyone that telehealth, again, isn't just with your primary care providers. All of our care providers, including our specialists, our behavioral health clinicians, our health coaches, care management, urgent care, they all have access to telehealth. And the beauty of our system is that they're all connected via our KP Health Connect. So when a member calls in, whether they're speaking with their primary care or videos in or calls in, whether they are speaking with their primary care physician or their health coach or urgent care, they're all seeing the same information for the health record for the member. And so again, just wanted to remind everyone that all forms are being represented. Any questions? Perfect.
This is Bill.
Hey, Bill.
I just have a terminology question, just so I understand, because this has happened to me over the last year and a half. It's quite interesting. So when I have a doctor or a specialist, I get all the forms in an email and I get to fill them all out so that when I'm scheduling my time away from home or away from work, I literally zip through because they've got all the answers and I have all the things. So when you're doing all this pre-work and history, is that considered telehealth or is that just a new process?
When you're filling out the forms and sending
But I
it
do all the
via?
personal history, family history, and all the forms, and then I don't have to be away from work. You know, cut a half an hour off my time away from work because I've pre-filled out all the forms. Is that telehealth or is that email or how do you quantify that?
I don't think there's a perfect answer. I think it's basically you're augmenting a face-to-face visit if that's what you're doing, wisely using technology to do stuff via technology, which is more efficient, more convenient, provides structured data for the provider if that's helpful, than relying on paper and pencil or just conversation for the doctor to take down the information. I wouldn't call that telehealth if ultimately it's a face-to-face visit, but if that was supporting a video visit, then I would say that's just video visit with using those technologies to augment the video visit. And again, really where we're going and where everyone should be thinking about is what's the best way to accomplish the task at hand, and how do we use technology, how do we use all the different modalities, which some are electronically supported and some are face-to-face, to best meet a member's need. Sometimes it is, for new patients, it's great to meet people face-to-face. When somebody has a heart concern, essentially, you got to listen to their heart and see if there's a heart murmur there, or if it's an irregular heartbeat, which you may not be able to, which you probably can't do unless you had special monitoring devices at home. So that's a better thing to do in the office, but there's certain things that are absolutely fine to do via emails, via questionnaires, via chat when that's available, or via telephone or video. Often follow-up chronic condition management is really well done via digital means. And then when you add to that, blood pressure monitoring, which we're now able to bring into the medical record and things like that. So to answer your question, I would say I wouldn't get too hung up on the terminology. It's really what's the goal of the healthcare and how do we best achieve it, getting away from the clunky, inefficient, over-expensive, labor-intensive things that we've always used in healthcare to date.
I think it just accelerates people's use of time away from work, and enhances their experience.
Yep,
Yeah.
absolutely.
I kind of think of e-visits, Bill, when you were talking through that. So for e-visits, when you have a situation where it's I just take me for example. I used it a couple of weeks ago for a situation that I didn't feel like I needed to see the doctor. I didn't feel that I needed to have a conversation. It was easier for me just to complete the form, with the myriad of questions that we ask, and for the physician on the other side to provide me with kind of the next steps action. So I guess that's kind of the similarities I see with what you have been doing.
And then there is diversity in bias issues. If you have people where electronic stuff may not work, when somebody has low literacy, when somebody doesn't have access to a smartphone or easy access to the web, or pays for data, or there's language barriers, or whether there's behavioral issues that create engagement barriers, really face-to-face is probably better. So it's a matter of having that sensitivity. And we're getting better at it. I mean, there's definitely been places where we've looked in retrospect and had quality review where telehealth has been used where it shouldn't have been. And so I think we're much more sensitive to that now, and making sure when conditions aren't getting better that next visit is a face-to-face visit, where a year ago or 2 years ago we might have said, let's continue with doing the telehealth because we're pretty optimistic about it. So I think we're tracking that data, seeing where it's not effective to use telehealth, and sometimes third complaint on the same thing that's not getting better, probably better to be in the office. It's just more likely to be a little less directed, and more likely to consider alternative hypotheses diagnostically. So it's not the answer. There's both. You could underuse and overutilize telehealth, and so it's finding just like anything else in healthcare, what's the appropriate use, the best use, the optimum use, optimizing with a member's time as part of it, with the efficiency of the visit, with the source, the channel of data that you're getting, or the lack of channels you might be getting with email only, or video where you may not have real vital signs to work with. So it's really, we're getting more and more sophisticated with that. We're not there yet. I mean, that's a work in progress. And then communication too. I mean, we know we're starting to do trainings.
I think that's...
We're starting to do trainings internally. We found out there's a few physicians who are super skilled at doing video visits and phone visits, and are having really higher than average kind of member communication satisfaction reports. And so we're talking to them, and what do you exactly do to make those visits go so well?
To cap it, I think you gave an awesome answer to the question I should have asked and didn't, which is that telehealth is evolving, in its methodologies and technology and equity, and it's something we need to just really promote, so to speak. Leave it at
absolutely.
that.
And think about it, not promote without consideration, and make sure it's being done right? And what we're doing is unique, doing it across our entire system. I'm sure there's plenty of other behavioral health groups and clinicians who really are doing great stuff and mostly using virtual. We just know the data is that's where behavioral health is happening these days. We know it's being used by primary care groups and some specialty care groups. But again, without a value-based system where we're not really worried about generating RVUs for our medical group to get paid, the incentive is for us to use it and to optimize it.
You guys have 15 more minutes.
Okay.
The only additional the thing I'm going to attach to what Bill's just talking about is that telehealth is dependent on, as you described, literacy, language capacity, technology availability, which is both where the person lives and whether or not they can afford it. And if it becomes the only methodology for receiving care, we've done something bad. And the key is to be able to use its capacity, but also not to make it the only way that people get care. So continue on with your report.
And again, we do have the data on use of our digital interface for OEB members by race and ethnicity and language status. We haven't pulled out the data that we're going to share by ethnicity, but we should probably do that next time. I'm sure we might be asked, and we should probably be thinking about that using that lens as well. Just one nice telehealth story was published recently. I think it was OPB that published the article in this story. One of my physician internal medicine colleagues who works at the Gateway Clinic, who has a primary immunodeficiency, so will not respond to vaccinations, and really is a situation where she could not work in a face-to-face environment. But she is now, I mean, this isn't standard, but she is a telehealth only primary care physician. She's been a strong and excellent primary care physician with us for years, and is now continuing to able to practice and actually maintain her panel, at least for the relationship aspects of it and the visits that don't require face-to-face visits, despite having a chronic medical condition that would make her unsafe to work these days in a medical office. So that's a nice story. Without this, she would really need to go on a medical disability or retire. So Great to have this. The data I'm going to say is not super exciting, but we can go on to the next slide and we'll run through some data slides here. So this is comparing OEB use of telehealth versus our book of business. The first two slides are from Q3 2020, or the first two bars. Second two bars from Q4 2020. Next two bars from Q1 2021. And next two bars from Q2 2021. So that's the last data that we have. The observations here that essentially OEB isn't behaving differently than our book of business, though has a just slightly more video visit rate that's higher, just a couple percent higher. And you can see the numbers there expressed in visits per thousand. The trends you're seeing for the blue bars for the face-to-face have related to the way we're building our schedules related to COVID, going from what was in late 2020, 40 to 50% in office for both specialty care and primary care. And now we're at 70% for primary care and a little bit more than that for specialty care. But there is variation in specialty care for services that can do work by video and phone. It's being done primarily that way, such as mental health, and then other departments that need more procedures are doing more face-to-face. Next slide.
Hey, just a quick question. Just want to chime in. If you could go back to the previous slide, this is Matt from WTW. Can you talk a little bit about this telehealth utilization? Is this what you're seeing pretty primarily across your book of business? It seems to be like this would be the natural progression as we are sort of getting more comfortable, more people are getting vaccinated regarding coronavirus.
Yeah, it's the same. I mean, you're looking at the right-hand slide, the right-hand bar for each couple there is the book of business, and you can see it looks pretty much exactly the same. So this is what we're seeing. I mean, we know how we're building our schedules. We're responding to customer demand. We're responding to physician needing more face-to-face visits. So we've been able to adapt. And so I think it's probably correct if I'm right, about 80 to 85% face-to-face versus video prior to 2020. And now we're at about 70%. So when there was a trend towards increasing video and virtual care prior to coronavirus. So we're not quite there, but we're looking at 75% now is what we think is a sweet spot. But we're tweaking as we go.
Thank you.
And again, bottom line here, the main thing we're trying to show is that OEB and our book of business are virtually identical here for a commercial book of business. Next slide, please. So the left two bars there are primary care. The next two bars are with Q1 and Q2. Next two bars are specialty care. And then right two bars are behavioral health. You can see the behavioral health continues to be primarily video visits and phone visits. Obviously, there's face-to-face treatment going on at our for some situations, for in the emergency room, behavioral health, face-to-face visits in certain situations where there are barriers to using virtual technologies. Face-to-face care is going on in our ambulatory inpatient unit, our Brookside unit, but the majority of care is going on by video, which really provides information in terms of good eye contact on video, decreased anxiety around travel for members who are anxious, and some, depending on the backdrop people use, some information about somebody's home context as well. The other bars, you can just sort of see changes over time with the reduction in primary care visits here from Q1 to Q2 was in Q1, the vaccination visits got included as a primary care visit in Q1 2021. So that actually include, even if they didn't include other primary care services. So that was a spike of when we opened up our, got to be given, that's what you saw that. And as it shifted over to the Oregon Convention Center, that was less. So, and then you can see the call volume in primary care and e-visit volume has been stable. Significant use of e-visits. That's our algorithmic supported primary care visit that has about 60 different common primary care conditions. A member fills out a questionnaire. The system is preloaded for the member's medical history, medications, allergies, and then that's reviewed by a Permanente physician, and then if appropriate, prescription offered. If chat's appropriate, that happens. Further information is needed. They're contacted to complete the visit. So that's been a successful program, and it's not a lot heavily used, but it does have significant uptake with a new kind of visit. The middle two bars is specialty care, and you can see some slight increase in face-to-face visits over comparing Q1 to Q2. Otherwise, pretty stable. Then you can see the behavioral health visits with really a predominance of video visits and phone visits, with some increasing face-to-face visits over the time. I forgot, sorry, this is this is only internal behavioral health, or is this including external care as well?
It's both. It's both.
Okay, great. Similar patterns seen both places. Next slide, please. Just some more detail here we are trying to intentionally use more video than phones, just because the added richness of the video visit. We can do more, basic limited but basic sort of physical exams for musculoskeletal issues using video. I had a shoulder issue, and I thought it went pretty well. I had a video visit, and I don't think I was able to. My spouse was able to help me with some of the physical examination maneuvers, and I think we actually had a pretty good physical assessment of my shoulder and came up with a good treatment plan by video visit. And then you can see some increased over time face-to-face visits, and that's been intentional. Specialty care is the next slide. With really mostly stable utilization. We did see a slight increase in face-to-face visits as less concerns about safety of face-to-face visits. And again, whether it's appropriate to be doing video care or telephonic medicine, that still happens in specialty care. I think our virtual dermatology program is going extremely well. It's really lowered the day's wait and improved access for face-to-face visits for dermatology. Members either take a high-quality picture or they come in for a nurse photo, or we do it in the setting of another exam, and you do a good quality, well-lit, in-focused photo exam, and then we use a tool called a dermatoscope, which is kind of a microscope image, which gives can really suss out what's a concerning skin lesion with melanoma or skin cancer versus not. We send those images for a dermatologist to review, and they make recommendation. It's pretty specific. They can identify what needs to be biopsied or not. I should say it's pretty sensitive. And so there's still some biopsies that are negative, but a lot of things can be reassured and don't need a dermatology appointment. Similarly, with complicated rashes, either the member can take a photo or we can take a photo in the office, and that really does help focus it. Not 100%, but certainly a lot of things we can get treatment started while waiting for a dermatology visit, or we can often resolve the problem that we couldn't figure out in primary care. And again, that wouldn't work if you were a dermatology professional organization or a group. Your money is in the RVUs and bringing people in and doing procedures in a value-based organization. It's really how do we provide the best care for the member in the most efficient way. Next slide. And then these are the behavioral health visits. Don't be too alarmed by the lower bars in June. There wasn't complete run through of that data, and we expect that to be similar to prior months. And again, you can see a very high utilization of video care for behavioral health, some phone visit use, and then some face-to-face visit use. Next slide, please. Just speaking of, one of our digital tools that we're using are behavioral health apps. Two of those can be either prescribed or available on a self-serve basis. That's the Calm app and the MyStrength app. MyStrength is from the Livongo is the vendor, which is now part of Teladoc. And the MyStrength is a CBT based app. It's pretty sophisticated. It uses sort of CBT methodology to help with anxiety and help with depression. It's really not adequate as a management program by itself, but for more simple cases or sort of pre-depression or non-clinical anxiety, it certainly can get people back on track. It has a specific module related to COVID. It actually brings in spirituality, which is, I think, pretty cool. And often we don't go there, but I think MyStrength goes there in a very nice way that can help people bring the strength of their spirituality into helping with their behavioral health issue. So sometimes our behavioral health therapists or our primary care behavioral health consultants will recommend MyStrength as an adjunct to the CBT tools that we know are evidence-based and they're using in the office. Calm is a mindfulness app as well as an insomnia management app that's very gentle, very appropriate for self-service, very appropriate for people who are either emotionally well or stressed or have clinical actual clinical issues. Those are both available for self-service. The other 4 apps there are things that can be essentially prescribed or prescribed and downloaded when someone's working with a behaviorist. We have done some evaluation of Cbt apps, which are the 3 on the bottom, when recommended by a behaviorist, and pretty good. I mean, these aren't randomized trials, so there's always going to be some improvement based on other things that people are doing. But when we've recommended the apps, we're seeing 80% improvement in moderate depression. Improvement is greater than 5 points improvement on the PHQ-9, which is a standardized tool that we use both to diagnose and monitor depression, and then 25% go into remission, which is getting to a PHQ score less than 7. Usually scores are 15 and up for a diagnosis of moderate depression. So, or 15 to 25. Yeah, Tom.
You've got 3 to 5 minutes left.
Great. Well, I think I'm done.
Well, that's even better.
Yeah.
Any questions or comments from committee members? My only one for the apps, I assume they're all in English.
I'm not sure. We'll check and find out.
Check into that.
Yeah.
And
great question.
And see whether or not in particular, getting it in Spanish would be great. And it's going to be big organizations like KP and MODA working with its vendors, virtual vendors that will push that. So we should be asking for it and telling people, if you don't have it now, we want it within 6 months or 12 months or something like that. Okay, thank you.
With sort of the app technology, I mean, these companies, it's a world. I mean, it's not just having to go in the United States because they don't have to be regulated, because they're really not healthcare. I mean, they're health improving, but not healthcare devices. So certainly they would want to see their market around the international.
Yeah, that'd be great. Okay, thank you. I think we're moving on to MODA. Bill.
Great.
Hi, Bill.
Hi, everyone. Okay, I'm going to show you some slides on MODA's telehealth utilization. I've got 9 slides, and they'll go pretty fast. They're similar to what we've seen before, just updated with some more data and a couple of new reviews. And I also, I had the benefit of listening to some of the other presentations and questions. So although it's not in the presentation, I went ahead and pulled telehealth utilization by race and ethnicity. So if anyone had some questions on what that looks like, I can answer that at the end.
If you could fold that into your conversation, that'd be super, Bill.
Okay. Sounds good. So we'll just start off. We'll go to the next slide. The next slide just has explanation of the data. This is all claims paid through August. I cut off the last couple of months, which were incomplete, so you just recognize that. Nathan mentioned that as well in his data. I guess the only other thing is just all of these graphs are similar. They're going to show the count of services per 1,000 members per year, and some of them have percentages. So that'll become clear as we go through it. So let's go to the next slide. So what I've got here are a few slides that show the number of telehealth visits for different categories of services. So we're starting off with primary care. So primary care office visits are still behind pre-pandemic levels. You can see that the plum colored bar is the total number of primary care office visits, and then the orange one is how many of those were in person, and the blue one is how many were telehealth. So you can see that there was a spike in the telehealth when the pandemic started, and that has come down slightly. It's too early really to tell whether or not that decrease at the end there is an ongoing trend or whether or not that level is going to be stable. It could be just random variability combined with the incompleteness of the later months of claim data. So we'll know more in a few months what that's really going to look like. In general, though, also you can just notice, I mean, this doesn't necessarily have to do with telehealth specifically, but it's clear from the plumb line that the number of people getting, or the number of primary care office visits being delivered these days is still not quite recovered from pre-pandemic levels. So let's go on to the next slide. This one's about other primary care. That's mostly recovered. Other primary care is all these other things that occur in a primary care setting: screenings, immunizations, contraceptives, all those peripheral services. And you can see that those have a pretty significant seasonality component to them as you look at the graph, the two big spikes in October. And then you can see, of course, the big dip in the middle there where the pandemic started. But the good news is that these services have mostly recovered, and almost kind of giving you the impression that, like, for people who maybe go to see their primary care physician regularly but don't actually have a required service that they need to get there, such as, you know, keeping up on their immunizations or whatever, or their annual testing, that those are the visits that are not happening, whereas the ones that have a service associated with it, like an immunization, those are continuing to happen at a similar rate to what they were. So it's good news for the various quality measures and other things that people are still tending to get some of those other services, even though they can't get them with telehealth. It's hard to get immunization with telehealth. Okay. And not hearing a question, I'll just keep going. So specialist office visits, that one follows a pretty similar pattern. Specialist office visits are down less than the primary care. Those are down about 2% since pre-pandemic, just sort of on an average basis. And looking at in telehealth, again, it's just like primary care. It spiked there in April. It's come down slightly, but it's not clear that that's going to be a trend. It probably is going to be pretty stable, the way it appears. The way it appears to us, the level of specialist telehealth utilization. All right, we'll go to the next slide. And this one looks very different, clearly. There's a bunch of stuff going on here. So behavioral health has substantially migrated to telehealth, and there's a lot of potential explanations for this. You know, talk therapy is particularly suitable for telehealth, given that you can see the person's face. So it's maybe that's a little harder, you know, to try to understand what's going on when, you know, their face is covered with a mask. And so it just is maybe a particularly convenient way to deliver those services. So you can see there with that blue line, the telehealth utilization is on the order of like 2/3 of all visits. And the overall utilization for behavioral health services has gone up significantly since the pandemic started. And that might be pandemic reasons, but also it could be related to the added convenience of being able to do the visit with telehealth. Because you can see before the pandemic, the behavioral health visits were practically non-existent, and now it's just completely taken over.
So, Bill, do you think that's like maybe I'm looking at the numbers, is it like about a 30 to 40% overall increase in utilization?
Yeah, I think that's about right. Yep.
Thank you.
Yeah. All right, well, let's go to the next slide. And this one is just comparing now those three types of services on the same graph. And you can see about 70% of all the behavioral health services are now delivered remotely. And the primary care is next the specialty care is next, or we call it non-primary care. Any other physician except for a primary care physician is in that blue line, and then primary care is just slightly below that. And you know, all three of them, you know, not much being done before, but after, you know, it looks like those are probably going to be the trends. And then I've got a couple other slides here that relate to these. So we'll go to the next one. This one, I looked at whether or not a provider has delivered a service via telehealth, looking at every one of our providers who had at least 20 claims, so we get at least a sample, and how many of them are actually doing telehealth services. And so this graph here shows the percent of providers that it shows the percent of providers whose telehealth percentage is in one of the following categories. So for example, on the far left side, there are some providers for which 100% of their visits are telehealth. And that represents, in that category of providers, for behavioral health, it's 40% of them. So 40% of our behavioral health providers are doing nothing but telehealth for the MODA population, the OEB population. And then conversely, if you look at the other side of the graph, there with the non-primary care and primary care bars, the teal and the orange bar there, about 2/3 of them are doing very, very little telehealth, with everybody else sort of falling in between there. And that shouldn't be a big surprise, looking at the graphs I showed you before. But I just wanted to highlight this because there's some providers that have really adopted this, and those providers are probably making up a bulk of the telehealth services being delivered. And there's some, it's just like, there's people that gravitate toward technology, and probably some of the providers are no different. They're comfortable with it and they're doing a ton of visits like that, and some of them just are not.
Bill, when you talk about, quote, provider, is that an individual physician or nurse practitioner, or would like the Providence Medical Group or the Legacy Medical Group be one?
I knew somebody was going to ask that. And so this view is just the individual providers, but I also went ahead and took a look at the data by system. Now, it's not possible really when you look at a health system to divide it out into the behavioral health, primary care, non-primary care, because a lot of them have all of that. But you will see that it's, as you would expect, like within a system like OHSU, there will be providers that don't ever use the telehealth service, and there will be providers that use it a lot. And so if you just look at, does OHSU offer it? Yes. And so the numbers by health system they look better than this in terms of there's more telehealth being delivered. So for example, the number, instead of 2/3 of the providers doing little to none, it's more like half doing little to none.
Yeah, it would be interesting to, again, take the top 5 delivery systems that you work with and see what's happening on a quarter-to-quarter basis. And again, using the total is fine. Is to see whether or not you see migration within the large groups, or whether or not they have kind of found that right level for them at this point.
Yeah, that would be kind of interesting. And the data, if you think about the previous graphs, I mean, there was definitely a spike back last April, and it's definitely come down a little bit since then. Just the question is, when you really dig into it, there's probably some that are going in each direction. Some of them are maybe continuing to increase, and some of them maybe even are decreasing. But yeah, that may be the top 5. That'd be kind of interesting. Well, I'm going to go, the next slide is just this very same data, just for people who are more number oriented than graph oriented. We'll go to the next one, and this is the same data, just in a table form. And so just to put some more specific numbers in it, you can see there, like I mentioned, in terms of behavioral health, 40% of the providers, that's all they're doing right now, at least for our patients, is telehealth. And the non-primary care and primary care, you can see there toward, like the number I pointed out toward the bottom, anywhere from 0 to 10% of their visits, you got about 2/3 of the providers doing little to none. Very few of the specialists and primary care providers doing a substantial portion of their visits with telehealth. Now Now that's my last actual slide, but I can give you some examples of what the distribution of this looks like by race and ethnicity. What I found was that there is not a lot of evidence, at least this was my hypothesis. I was wondering whether or not it would be the white group that used the services more, and the other racial and ethnic groups maybe would not have taken advantage of the technology. And it turns out there's no evidence to support that. The highest utilization of telehealth services for specialty care comes from the Black or African American racial group, and white is kind of it's actually slightly below average. When you look at primary care, the highest percentage of telehealth utilization is from the Asian racial group, and again, white is like right at the average. So if you were concerned that maybe there would be racial and ethnic disparities about utilization of telehealth, that doesn't appear to be the case, at least in the early view of looking at the data we have. We'll continue to monitor that, but that was at least pleasing for me to see. There were some stark differences in terms of whether or not somebody marked refused on their survey versus just that we didn't have the data. And the people that refuse to answer tend to be people who are high utilizers of telehealth. So that was a kind of an interesting finding. If you look at the
can you say that again, Bill? I missed that.
Sure. So we look at our data, our race and ethnicity data. There's lots of categories. There's white, Black, Asian, American Indian, etc. But there's an unknown category, which is reasonably large, and then there's a refused category that people just didn't want to say. And it was those people that didn't want to say what their race was that they had high telehealth utilization.
Okay, thanks.
Yeah, and then in terms of ethnicity, that was pretty consistent. There were not very many differences in the telehealth utilization by ethnicity, all within a pretty standard margin of error in terms of like non-Hispanic versus Hispanic. They were right about the same, with the non-Hispanic being just slightly higher in terms of their telehealth utilization. That's what I've got for you. Any other questions?
I have a question that Dr. Bachman used as he was describing how Kaiser Permanente was dealing with things, talked about their system, because their physicians are salaried. They have disconnected the RVU, face-to-face doctor office visit. And I know that the state is working at trying to move to a value-based system. I know that MODA has been working with its delivery system colleagues to figure out ways to move towards value-based payments, and telehealth payments is an example of that. Is a minute of your comments about how you're doing and how it's working, and obviously without, I'm just talking about more of the general direction that you're seeing as you as a health plan work with your colleagues around value-based systems, which I think telehealth can play a part.
Yeah, I can. My general comment there would be we are definitely moving toward shifting dollars from fee-for-service to alternative methods of payment. And we use several of those methods of payment. The capitation, we have a couple different types of capitation. And then we have pay for performance bonuses, and we also have total cost of care, shared savings type of payments that we make, and collectively, yeah, we're definitely moving in all of our lines of business over that way. If you look just from a macro perspective, probably the CCOs are one area in the state, and we manage the Medicaid population for a couple of regions in Oregon. There's been a substantial investment by the OHA in developing alternative payment methodologies, and so they're doing quite well there. But also OEB is with the coordinated care model that we have. It is doing extremely well, particularly in primary care. There's some primary care. I couldn't give you a list right off the top of my head, but for OEB and PEB members, there are some large primary care operations that are now 100% on capitation. We don't pay them any fee for service, and so they're paid with a flat rate per member, with the opportunity to earn bonuses for controlling cost of care, the downstream cost of care, and also quality bonuses. So yeah, that's extremely important, particularly for primary care, but across MODA and all of our lines of business.
Yeah, it will be interesting to see how, next month we're going to be getting an update on PCP 360. I know that has been the foundation of CCM 2.0. The issue around how to then start wrapping in all the elements of care, particularly specialty care, will be fascinating and obviously a very important evolutionary step.
Yeah.
Okay. Other questions or comments from committee members?
No.
Okay, so I have it. Thank you very much, Bill. Very helpful, and I really appreciate MODA's effort at kind of diving deeper into the issue around health equity. I think the board will be pleased with both yours and Kaiser Permanente's efforts in this regard. I have it at 10:41. And we were scheduled for a 5-minute break, but we're 4 minutes ahead. So we're going to make it all the way to 10:50 before we start again. So we'll see you all in about 8 minutes. I'm sorry, I'm a minute late. Is everybody back on board? Everybody ready to get started again? Okay, so we're now going into talking about dental utilization and in particular COVID impacts. And again, this is we've been following this over the last year and a half or so. And what I see in terms of timing is that we're going to start with Kaiser Permanente, and we have Dr. Pilstrom joining us, and Rick I don't know if it's Mole or I'll let you do that, Rich. Okay.
No problem. It's Rich Mole. Thank you.
Thank you.
All right. Well, thanks, Tom. Good morning, everyone. And can everyone hear me okay?
I can.
Great. Well, thanks for welcoming us back. I'm Dan Pilstrom, General Dentist at the Cedar Hills office for Kaiser, and I'm joined by Rich Mole. And we're going to go over the OEB utilization and just talk through some of the results of our OEB membership outreach, which was really positive. And then, as always, as we go through this, if you have any questions, just let me know. Next slide. Okay, so this is our OEB utilization of all services per 1,000 through July. The blue line is 2019, the orange line is 2020, and the green line is 2021. And
this is Tom. Mine the screen is not moved. Also, I'm hearing noises in the background, so make sure everybody mutes. Rose, have you advanced the slides? Is it just my computer that's going wonky? There it is. I have it now.
Yeah, Tom, it's you.
Okay, I got it now.
Okay, and this basic trend line we'll see kind of throughout the presentation, with a couple of exceptions. We're basically seeing utilization similar to 2019 for overall services, and you can see that top line trading places back and forth from month to month. So this data is through July, and back when we were probably everyone was a little bit more optimistic about where we were with COVID. But despite maybe some bumps in the road, I'm pretty cautiously optimistic about dental utilization moving forward. Next slide. This is diagnostic and preventative services per 1,000. So these are things like dental checkups and cleanings, and include dental x-rays, fluoride treatment, sealants, these types of services. You can see that 2021 is pretty similar to 2019 performance. And I think this is some of the things that have helped keep these numbers up has been some of the technology upgrades that we've had over this year, and optimistic about 2022 and online appointing. In addition, I think we got a boost from some of the OEB outreach that we did with that Rich is going to go over on our next slide.
Thank you, Dr. Pilstrom. And thanks to everyone for allowing us to go over these numbers. As you mentioned, Dan, my name is Rich Mole. I'm the Director of Ancillary Services for Dental. I have some great results actually to share with you today. So it was about a year ago when we really started the discussion around preventative services for our membership. And frankly, some of the feedback that we were receiving at the time is once our members accessed our system, they were very happy with the services provided, but there was a challenge in getting them into the KP dental system. So this was our first solution we undertook to solve that. We had a targeted letter campaign that reached out to about 11,000 OEB members. We kicked this off in April and May, and I'm glad to say that we're seeing some good results at this point. So I know there's a lot of numbers on here, but maybe I could walk through them real quick so everyone's on the same page. We pursued this letter campaign in 4 tiers, and you can see our tiers on the left. Where tier 1, we focused on members that have not been in the system for over 24 months. Tier 2 being 12 to 24, tier 3, 6 to 12. And tier 4 were those members who have never seen us or been in a KP dental office. And you can see the member count for each. When we talk about results, you can move to the next columns over where you see no contact through scheduled. The no contact column defines those members that received a letter, but we did not hear from them. So no action was taken directly from them, and they did not get an appointment with us. You can see that percentage is still rather high at 66%. 2/3 of that membership, which basically means that we will continue with our efforts to contact them and drive them into the system. The rest of the columns represent folks that did make appointments with different outcomes. And so if you look at canceled, about 2.3% of membership did make an appointment, but unfortunately canceled and or rescheduled. 27% did complete their appointments, just 1% no-showed, and about just over 3% are currently scheduled to have their appointment, and we'll be getting that done in the next couple weeks. I included the percentages from our June 1st meeting so we can see the change as these members moved from scheduled, almost 10% scheduled in June, to now, 27% completed here on September 15th. That's when the data was run. So if you take a look at our action taken, the last 2 green columns, overall, we reached about 1/3 of this membership at over 3,500 members. Frankly, when you look at letter campaigns, we were a bit surprised at this percentage. This is great feedback from that membership. I think it speaks to their want to get into KP Dental, and they just needed a little bit of pushing and us making it easier on them to complete that. So that also speaks to a positive future where we can continue to reach out to them and drive them to the system in different ways.
Question here.
Yes.
So the no contact column, is that sync with your book of business?
No, that would not sync with our overall book of business. I can check if it would sync with those that we have never seen in our system or haven't been in our system for 2 years. I could look at that.
This is kind of different in the sense that we don't generally do outreach to members like this. They get like a new member welcome thing, but we don't frequently do outreach programs like this to most of our other business lines.
So taking the glasses half full approach, getting 27% is good news.
It's really good news.
Absolutely. Yeah.
Thank you.
Yeah.
You bet.
Anything else, Rich, on that slide?
The last couple bullets on our technology updates and enhanced benefits, this has been included in previous meetings, and we talked about it in June. But just wanted to make sure you knew we were still on track for these technology updates hitting in Q3 and Q1 of next year. We are pursuing the online appointing early next year, and I think that's going to make a big difference to our member experience on just streamlining that appointing experience. And enhanced benefits, just as a reminder, enhanced benefits for preventative dental care went into effect on Friday with $0 copayment for those preventative services.
Okay.
And that's all I have, Dr. Pilstrom, if you want to take it back.
Great. If there's no other questions, we'll go to the next slide. Continue some of the utilization data.
Dan, Dan, this is Tom. I just thank you for your organization listening to what our concerns were, and I am a glass half full person, and 27% of people who needed to be seen now have been seen. That's good news. Not surprising. The never seen have a lower percentage than everyone else.
Yeah, I was heartened by it, and I think we just need to keep chipping away at it, and we may need to do this on a semi-regular basis.
Agreed.
To keep that up.
Yeah, agreed. Okay.
Great. So this is periodontal services and dental fillings utilization per thousand. Periodontal services are things like dental cleanings, like periodontal maintenance cleanings and deep cleanings for patients with periodontal disease. We see a slightly lower utilization here, but I think approaching 2019 levels. The reminder systems and pre-booking systems are pretty much all in place as they were in 2019. So we should see those rebound, I hope, in the coming months. For dental fillings, we see pretty close performance with 2019. Next slide. This is specialty care. Endodontic and oral surgery are some of our most, most common specialty care services that are accessed. So endodontics are things like root canal therapy, oral surgery, think of wisdom teeth removal, things like that. These services, when you get down where the number of services are generally lower per thousand, these numbers tend to fluctuate month to month, but I think we're seeing trends that are similar to 2019. Next slide. Last slide around utilization, just crown services and partial dentures. Again, generally the number of services per thousand with these is relatively low, so you expect to see some fluctuation. Seems like it is maybe climbing the 2019 number, not sure what it will look like in the future. Both crown services and denture services tend to happen toward the end of a patient's journey in care. So think about a new patients or recall patients coming in that maybe haven't seen us. They get their teeth cleaned. They might need some fillings done. They might have some other dental care that needs to take place before crown and denture services are done. So we might be seeing some lag from the depressed utilization earlier on. And last slide is just a thank you slide. And I guess my only parting comments is that overall, I'm pleased with the OEB utilization. I think it'll be really interesting to see what happens in September, October, and November. There are some macroeconomic factors at play in the dental industry. COVID numbers increased in the fall here. We've seen some effects of labor shortages on dental staffing. So I wouldn't be surprised if utilization takes a dip in the coming months before rebounding again in 2022. But I am optimistic in the long run that we'll work through this. And we will keep you posted as we do.
Actually, it reminds me, we haven't raised this issue, the question, but one of the requirements has been for the health industry in the state is that everyone is vaccinated for COVID-19, and there's been issues or questions about that impact for the people who refuse. Is that has that issue impacted Kaiser Permanente at this point for dental services?
I think that it has some. I think we did a really good job of getting staff vaccinated early on. We didn't have a lot of people. I don't know, Rich, do you have an update on, like, I know for dentists, we didn't lose any from that requirement. I'm not sure about hygienists and assistants.
Yeah. So we're under, our percentage was under 2% when you looked at hygiene and assistants. So a small percentage of individuals who will not move forward with their vaccination, but overall, we're refilling those roles, and we don't expect a long-term impact there.
Okay.
That being said, I think that there is, especially with dental assistants, there's just a real labor crunch, and it's been going on for a couple of years, but it's just really coming to a head. And I think you'll hear that from the other carriers as well. Just this is just something that's hitting all dental staffing.
Okay, that's great. Thank you. I think obviously this is one of those issues that, and yet for members to feel comfortable receiving care, knowing that the person who's right next to their mouth has been vaccinated is kind of a requirement. So
we think so.
okay. Yeah. Okay.
Yep.
All right. Thank you very
Thanks.
much. And next up, is it Delta Dental?
I believe so.
Yeah,
I think we need to go one more slide though. Perfect. Good morning, everybody. Terry Barrichello from Delta Dental of Oregon. And go ahead and go to the next slide. So this is, again, just to follow up from what we presented in the past. And the data is changing, and the recurring theme in my presentation will be a little different than that of Kaiser. We're definitely seeing an impact of utilization, which I attribute to the Delta variant rise, as well as that labor shortage that was referenced. And I'm going to talk more about that after I go through the numbers. So this slide, we're looking at unique visits. And you can see that 2021 in the green line got off to a really strong start. But through the summer, when I think news of the Delta variant really started hitting, we saw an impact to utilization on a unique visit count. Go ahead and go to the next slide. So here I wanted to look at, I care very passionately about, especially the preventive services. So I wanted to look at breaking out the child and adult preventive services. And we continue to see a difference in utilization between the two different segments, with children not seeking services or having services done at the same rate. And it makes sense, because especially for those 12 and under, they don't have an opportunity or hadn't to be vaccinated. And I think that plays a role into a parent's confidence of taking a child in for prevention. But I actually am really pleased with the ages 19 and above that you see at the bottom of the slide. The green line, that's 2021, really performing, on par this year so far. And the drop off at the end there in August is just claims run out. So I wouldn't read anything into that at this point. Go ahead and go to the next slide. So further looking at kids, we broke out the preventive services into fluoride treatments and sealants. And there's a significant discrepancy between the two. And what I read into that is, at least when I was in practice, very often I would see a kid for their recall exam, their cleaning, and they would get their fluoride treatment. But if they needed sealants, or if sealants were recommended, we often reappointed them for a separate time. And I believe if that is the case, that may be playing into hesitancy to return to a dental office for a subsequent visit for sealants, because the sealants are really lagging behind last year and 2019. And it's, I think, a really important takeaway for all of us, on my side anyway, to really reinforce the safety of seeking dental care. And again, I'll talk more about that further into the presentation. Go ahead and go to the next slide. And here we break out the child and adult cleanings. And again, the adults are performing fairly well, a little bit of a dip in through the summer. And for children, we're lagging just a little bit, but not as badly as those sealant, the sealant gap. Go ahead and go to the next slide. So here we're looking at restorative services, that would be fillings, and then crowns at the bottom, performing quite well through the year until the summertime, and we start to see a hit. There's an additional factor, again, that we'll talk about that, especially as we're looking at fillings and crowns. What may be impacting this utilization is not only COVID, but the downstream effect of COVID on staffing issues and appointment availability. We'll talk about that in a little bit. Go ahead and go to the next slide. And finally, just the specialty services, it's the same story. I'm really pleased, though, to see how strongly the periodontal services have rebounded through COVID and performing really well in 2021. And then go ahead and go to the next slide. So this is a slide that I presented before, and all of these factors, they still exist to different degrees, but I grayed out the ones that are not, that I don't believe are really strongly impacting utilization. So I'm going to talk more about the three that are in black there, starting with the infection and hospitalization rates. So let's go ahead and go to the next slide. And what I did is I pulled a screenshot from the Oregon Health Authority, their COVID case rate count. And I found this really interesting because if I could have overlaid them, and I'm just not savvy enough to have done that for you, but I think that you would see an interesting correlation between the spikes here on this slide and the dips in utilization in different categories for appointments. And I think that a lot of that is, there's just a hesitancy. The more that they're hearing that in the news every night or in their social media feeds, there's a little bit of a sense of, well, I can put that off. I'm not in pain, or it's, I'd rather keep my, kids at a lower risk of going out with all of this happening in the environment. Go ahead and go to the next slide. So there was a great study done by the Urban Institute in April, and it looked into patient confidence of seeking care. And this was at all types of healthcare, so including child well visits as well as dental. And they found that families were delaying healthcare for their children, specifically for the fear of exposure to COVID. And 1 in 5 parents did not get care for their children in the last 12 months. And really interesting also is that parents in low-income households were more likely than higher-income households to delay or avoid scheduling. So I think that that's something that I want to take as a takeaway. How can we make sure that we're getting the message out about the safety of seeking dental care so that we don't see disparities based on income or any other social determinants? And most impactful for us is that the most common type of delayed care was dental care, followed by the well child visits. So go ahead and go to the next slide.
I'm going to interrupt for just a minute, and I'm wondering whether or not, Ali, whether or not we can include this in our OEB messaging to our members, both entities and to members. It'd be good to be able to, in our communications, kind of focus on this.
Yeah, absolutely, Tom. I think Jackie's on the call, and we'll work on that.
Okay, so Terry, maybe you can talk to staff after, and just this is a very important, very important information, and I could imagine this being, a couple headlines and then bullet points, and we'll go from there. Thank you.
Absolutely. I can't overstate the difference. It was really interesting to hear my Kaiser colleagues talk about their workforce, because in the more private practice side, which makes up our network, we're seeing a dramatically different story. And there are multiple variables that are going into staffing shortages, and there's a paucity of labor out there, and then those who are out there have a lot of COVID concerns, particularly with hygienist assistants in front office. We're not seeing that so much with the dentists, but in the Journal of the American Dental Association, they just published this study and looking at the ability of the oral healthcare workforce and the willingness of the oral healthcare workforce to come back to work. And there is a difference between those two, the ability and the willingness. And they found on the ability side, the reason that there's a decreased ability, at least as was reported, is that there are a significant number of people who say that they have responsibilities at home, caring for elderly, caring for their children, and of course throughout last year, helping their school-age children. They needed to be at home to enable that. So their ability to come to work, was severely impacted by that. And it wasn't necessarily a key part of this, but one of the things I just would point out in general is that the auxiliary workforce in dentistry is overwhelmingly female. And I think that really speaks to sort of the difference in gender impact of COVID, and I really have to hand it out. I'm not a mom, but I have to hand it out to all the moms out there. Sorry. Secondly, there's a difference in the willingness to come to work, and by far and away, hygienists and assistants have reported that they're less willing. Their reported fears of COVID are significantly different than were reported by dentists. And also interestingly, dentists were far more likely than their staff to have already been fully vaccinated. And then to the point, or the question that was raised earlier about the vaccine mandate in Oregon and what we're seeing, we are hearing pervasively through our network that that offices have been losing certain personnel. I can tell you in our own offices, there was a percentage that they had. They were very honest about it. They told us, frankly, I don't have a religious exemption, and I'm not going to, I'm not going to fake something. I have personal issues, and we really appreciate that honesty. But unfortunately, we cannot, we cannot accommodate them in the workforce right now. So that takes additional people out of the already shrinking pool of healthcare workers. So it's hard. I think this workforce shortage is going to continue to impact utilization, at least on our data, for a good period of time going forward. At the very least, until the vaccine mandate has been lifted, and until I think some of the kids are able to be vaccinated and there's more confidence from in them going to school. Go ahead and go to the next slide. So this is the good news slide. I'm really happy to report that across the U.S. there's an extremely low infection rate among dentists, and it remains lower than other health professionals. Again, a JADA published study found that only 2.6% of dentists had contracted COVID, and the COVID contraction rate is based on community spread. There's still, I have been unable to find any evidence that there has been an in-office transmission of COVID, either from caregiver to patient or vice versa. Dentistry is, an extraordinarily safe profession. We're experts in infection control, and then with the additional COVID protocols, it's just that safety has even been enhanced. And I found it really interesting that 2.6% of dentists have a COVID rate, and then frontline workers, and it really speaks to the risk that our other healthcare professional colleagues are undertaking. Their COVID prevalence rate was 29%. So I just really also want to, for any of the nurses and doctors in the audience, I just want to say thank you for what you all are doing. And then and on my final note is a really interesting study out of Ohio State, because we've worried about those aerosol generating procedures in dentistry because our handpieces create those aerosols. And the great thing is that this study found that saliva is actually not a big source of the microbes that carry COVID. It was, they found that only 0.1% to 1.2% of what's in those aerosols was from saliva, and very, very little COVID in there. So that's, I think, a really great message for our patients and for dental care staff, that this is a very safe environment. So I'm happy to take any questions.
Any questions from the committee? Thank you very much, Terry. That was, as usual, a wonderful presentation, and it will be one of the things that I talk to the board about in terms of just the impact of why utilization is down, and I think the school districts and a lot of our entities that we support are having this exact same issues with staff. Even if you're at 90%, it means you've lost 10% of your staff, which can be really devastating. And if it's 20% or 30%, I don't know how you move forward with it, but we'll move forward. Thank you. Okay, I think we're on to Willamette Dental. Dr. Chambers.
Sorry, I thought
and
I was
Tiffany,
talking, but I was on
Tiffany
mute.
Link. There you are. I see you both. Okay.
Good morning. Thanks for having us. So I'm Tiffany Link, and with me today is Dr. Mark Chambers and Darcy Engel as well. So a quick update here on our new patient member outreach. So we created this new patient outreach program for all of the OEB members that have never been seen. We started this kind of throughout the beginning of this year and provided outreach to 3,700 OEB members. In response to that outreach, we've had a pretty good success rate. We're at about 49%, in which 1,818 members have already scheduled those appointments. So they've either already been seen or they're scheduled for an upcoming appointment. With this outreach that we started in March, we are waiving that office visit copay, the $20 office visit copay for this new patient appointment. We'll continue this through the 2021-2022 plan year, but so far to date, we've had 742 OEB members that have had that office visit copay waiver. And next slide. Great. So for overall appointment utilization, comparing 2019, 2020, and 2021 through August, when we look at January through August of 2019 through August of 2021, we're trending at about 80%, which is due to a lower patient volume, which we'll kind of talk about more on the next slide. That's very similar to what Dr. Varicella was mentioning. We're also experiencing a high number of appointment no-shows, which does have an effect on overall utilization, as this graph represents completed appointments. So the no-show appointments, these are booked clinical time in which patients aren't showing up for their appointments. So as those no-shows appointments happen, our offices do our best to try to fit in other patients, but without notice of canceling, it does make that a little bit of a challenge. So the percentage of no-shows increasing from 2019 to present is at 157%. And then 2020 to what we anticipate based on the current trends for 2021 would be an increase of 29%. So there is still, as it's similar to what Dr. Varicella was saying, just some hesitancy of these patients coming in for their appointments. We do send appointment reminders via their member preference. When they make that appointment, we ask them if they want to be notified via text, email, or voice. And they're sent 3 days prior and then again 1 day prior before the appointment date. Next slide, please. We wanted to throw this in just to kind of give you some insight as to what is happening with the current status of dental practices, not just with Willamette Dental. So the American Dental Association performs frequent and ongoing surveys to all dentists throughout the nation. And this survey specifically asks, what is the current status of your dental practice? So as of the week of September 13th, 37.3 dentists reported that they are open, but they're seeing a lower patient volume than usual. Not shown on this graph, but reported in the survey for Oregon specific, it was 44.7% dentists in Oregon are open, but again, that lower than normal volume of patients. And this is similar to what we are seeing as well. And I'm going to hand it over to Dr. Chambers.
Excellent. Well, I wanted to touch on one of the statistics that Tiffany shared, and that was the outreach to the OEB employees that had not come in for dental treatment. Out of that outreach, those 3,700, as she shared, 1,818 of them showed up. So just shy of 50%, which we were pretty pleased with. Similar to kind of what Dr. Philstrom shared, that he was pleasantly surprised how many people responded to the outreach. We were similarly, happy and pleased that through just little efforts of reaching out to those patients that had never come in, they were willing to come in, even despite, maybe hesitations with COVID and other concerns that patients are having. So we will continue to do those outreaches and feel that there's great value to OEB employees there. Going on to the next slide, this shows us from 2019, which is our blue line, 2020, our yellow line, and 2021, our red line. And you can see that for basic dental services, we're back to 2019 levels, in fact, surpassing in some months.
Dr. Chambers, what's the defined basic dental services?
Oh, you betcha. Yeah, thank you. Basic dental services are going to be fillings. So it's kind of your bread and butter dentistry. It's going to be your fillings. It's going to be your extractions. It's going to be root canals. Periodontal treatment would be included in that category. And to a certain extent, Tom, a lot of those basic dental services are really those procedures that patients are more inclined to come in for. If they have a tooth that they chipped, they're going to come in. If they
these are ones where people are having pain.
yeah, and sometimes not pain related,
or an obvious problem.
Exactly.
Yeah.
And we found that with these basic dental services, they're not going to put them off because of concerns over COVID. They're going to feel more comfortable. Whereas sometimes I think with preventative dental services, despite our encouragement and education on the importance of those preventative services, I think sometimes patients say, well, I'm going to wait a month or two, or I'm going to wait 2 months. Hopefully COVID will slow down. Things will, they'll feel more comfortable a couple months down the road, and they tend to defer or put off those preventative services. But we have been pleased to see that we are kind of trending back to those 2019 levels. As we move on to the next slide, looking at preventative dental services, very similar to the graph that Tiffany shared of kind of general utilization. And a lot of this, I believe, is driven by patient hesitancy to come in for preventative services. On the next slide, we dive a little bit further into sealant utilization. So if you can go to the next slide for me. And with the sealant utilization, we've actually seen our preventative services increase above 2019 levels. In part, we shared with you at our last meeting that we made a change in our decision support tools inside our electronic dental record that encourages providers to provide more preventative services to our patients with fluoride, with sealants, more frequent cleanings for those patients that need to be cleaned more often, and other prevention. But with that, we've also continued to do more outreach. As Tiffany shared, we went from 1 reminder call up to 2 reminder calls, trying to encourage patients to come in for treatment and to show up for their appointments, and make patients more aware of the preventative care that they need. The following slide looks at sealant utilization within group, the OEB employees, off of a risk-based approach. And there was a phenomenal study that was done that looked at 44,000, a little over 44,000 sealable teeth. And it looked at those patients on a risk-based approach. It looked at those patients that are low risk for cavities and those patients that were moderate, high, or extreme risk for cavities. That study that came out in August of 2020 was published in the Journal of Public Health and Dentistry, and it looks at the benefits of sealing those different risk populations. The outcome of that study was that there was significant value to an employer, or in this case OEB, sealing teeth that patients that had any kind of risk, whether there was moderate risk, high risk, or extreme risk for cavities. And on the flip side, significant more cost to the group if they didn't have risk factors, that there wasn't a value in terms of cavity prevention in that low risk group. And this study with others validates kind of that risk-based approach to delivering care. And on this graph, you can see through help with that decision support tool and encouraging providers to provide more prevention, around 60% of patients when they leave are getting the sealants when they leave. Now, some patients, like Dr. Varicella mentioned, that sometimes we have to reschedule for another day, and sometimes it's hard to get them to come back. But we have really made a push as an organization to try to get that treatment done, those preventative services, especially sealants, done at the same appointment, because we know that once somebody leaves, life gets busy and sometimes they just don't come back. On the following slide, it talks a little bit, or this dives into fluoride treatment. And the blue line being 2019, red line being 2021, and orange line being 2020. And you can see that, a little bit lower than 2019 utilization levels. In part, there is just a little less utilization for hygiene appointments, and typically these preventative services are being delivered at the same time as the cleaning appointment. The following slide, however, does look at the risk-based approach, similar to sealants. And you can see of those patients that are coming in that are either moderate risk, high risk, or extreme risk, we're averaging about 97 to 98% of them are leaving with a fluoride varnish. And this is independent of the age of the patient. If they are 50 years old and they are high risk for caries, they need that fluoride varnish just as much as the 16-year-old that's high risk for caries. They both have risk factors. Just wanted to, as we kind of wrap up our presentation, wanted to touch on a little bit on the staffing challenges that are being faced in Oregon. We've seen several things. When COVID started, there was a certain percent of the workforce that just decided that dentistry wasn't for them. Many of them had obligations at home with maybe children that needed help with school. Some had elderly parents that now needed a little more attention, or they were concerned that they might bring the virus home to an older family member. And that was a hit to the dental profession. The second thing that happened is that we started seeing some of the dental programs, dental schools, dental assisting schools, and hygiene schools either cut back their enrollment, or they were graduating those that maybe had a little less experience than previous graduates had been. Students that came out that were slower, that needed more coaching and mentoring to get up to speed to seeing patients. And that put a challenge out in the dental community. And then lastly is that we're seeing that, there is, although not a huge percentage, but those within the dental market that are refusing to go and get vaccinated. And because of that, the pool of potential applicants for dental assistants and front desk or hygienists is definitely less than it was before. We found that across the board, we've had to increase compensation through just about all job groups as we look to retain staff and realize the importance of retaining quality and good staff members. All these things will kind of cycle over time. And we've seen this in the past in dentistry, although this seems to be a little more severe than what we've seen in past changes in the workforce. And I'm sure we'll make it out of it, but a challenge nonetheless. Any questions that anyone has for Tiffany or I?
This is Tom. It seems that you would recommend that, as we talked about with Delta Dental, to use OEB to encourage, to highlight the issues around decreases in the utilization of prevention and the importance of it, and the recommendation that people, get in touch with their dental provider.
Yeah, well, Tom, I think that would be incredible. I think the more voices we have out there encouraging people to come in for prevention, the better. With that, what I'd love to see included in that outreach would also be, information on the efforts that the offices are making to make it a safe visit.
Right. To address the issue around that it is safe, that the staff are now being required to be vaccinated, that the use of PPE and all of those things that make the experience a safe experience. Yeah.
That would be incredible. Yeah.
We're all over it, Tom.
Okay. Any other questions or comments from the SEOW committee? So I think we're seeing again, as I commented about the Kaiser Permanente dental effort to outreach to the people who hadn't been seen. Congratulations and thank you to Willamette Dental Group for the work that you've done in terms of outreaching. Very important. And as you discussed, making this a semi-permanent activity to, or at least, something that we cycle through, because once we get people in, then we start, we're able to do the risk assessments and get the care that these people need. So again, thank you for your effort, very responsive to what we had asked. Any other questions or comments? Well, again, a very full morning. I think we're done for this session. The board meeting starts up at 1 o'clock. If there isn't anything else, I'll go ahead and close the meeting. Oh, I'm sorry. I keep forgetting it. Public comment. Do we have any public comment? Rose?
I don't have any, Tom. No.
Okay. And is there anyone on the phone that wants to step up? Not hearing any, I will call this meeting closed. Thank you very much for all of the participants. Really well presented and well prepared. Bye-bye.